25% of deaths occur at home. More than 70% of Americans would prefer to die at home. I'm just curious, how many people would prefer to die at home in this room? Okay. We now have the knowledge to be able to die at home because we know we have resources available in the home. And I think the reason that people would prefer to die at home is because they're surrounded by their loved ones, they're in their own environment, they're with their pets and everything that makes them happy. And they have a team of people coming in to help them with what they don't know. And that's hospice. So hospice myths. I want to stay home, so I don't want to go to hospice. So many people think that hospice is a place. Hospice is wherever you are. That can be a nursing home, an assisted living, independent living, your home. We've gone to the county jail. Wherever you call home, we come to you. Hospice is only for the last few days of life. Unfortunately, that still happens today, and that's what we're trying to avoid, is late referrals. Because again, we can't do our best work in 24 hours. I encourage referral sources to make hospice referrals early, even if you think that patient's on the fence and they're not going to meet criteria. We would prefer to come out and evaluate a patient 25 times and tell you the patient's not appropriate, but we tell you what to look for that makes the patient appropriate. And there's no charge. There's absolutely no charge for a hospice evaluation. So again, we would rather come out 25 times and tell you every time they're not appropriate, but the time that they are, we're able to get in there early and the family gets to feel the full effect of the hospice team. Hospice is only for cancer or AIDS patients. We still get this a lot too, where people think that hospice is only for cancer patients. Hospice is available for any patient with a terminal illness. That includes congestive heart failure, renal failure, anything that is going to take the patient's life would be considered a hospice diagnosis if they're terminal. It's not just for cancer and AIDS patients, Alzheimer's patients, dementia patients. It's huge. Choosing hospice means I'm giving up, when in reality it means we're giving you hope, because we are concentrating on the quality of life, not the quantity of life. And studies have proven over time that patients who receive hospice care live longer than patients who do not, because their pain's controlled, their symptoms are managed, and their affairs are in order. And that is so important. So many people don't have their advance directive in order, or their living will, or end-of-life care. We help with all of that, so the patient can pass knowing that their family's going to be okay. We're going to help handle that. And we don't just give up on the patient when they're no longer here. When the patient dies, we spend 13 months offering bereavement services, counseling sessions, memorial services, so that their caregiver is also remembered. Doesn't just stop when we aren't there. Hospice won't allow me to be involved in making decisions about my treatment. We encourage patients to let their voices be known. If the patients are alert and oriented, that's who we're speaking to. They make their own decisions, they make their own choices, and we encourage that. Of course, oftentimes we do get those patients who either they're demented or they have Alzheimer's and they can't make those decisions. In that case, we talk to the medical power of attorney or the next of kin. Hospice keeps dying people heavily medicated. This is a big one. I get this all the time. I don't want mom to have morphine. I don't want mom to be sleeping all the time. What people don't understand is when a patient is dying, it's like us when we have the flu. Do we want to eat? No. Do we sleep a little more? Yes. That's exactly what happens to the dying patient. They no longer have an appetite. They want to sleep. They want to do what makes them happy. And if sleeping makes them happy, so be it. We don't want to take that away from them. When we medicate a patient, we can't do anything without the doctor's consent. If we administer morphine, we always start at the lowest dose to determine if that's going to manage the patient. If we have to increase either morphine, Ativan, any other medication, we can only do that with the doctor's consent. And we're continually educating the family that this isn't the medication, this is the patient going through the disease progression. And it's our job to help them through that, because they don't know that, they've never done this before. So it's our job to educate them. Next. Late referrals undermine hospice value. Again, we talked about that. We can't do our best work in 24 hours. And we will come out 1,000,000 times if that is what is necessary to enroll a patient in hospice. Hospice is for the last 6 months of life for a reason. When a doctor refers a patient to hospice, the doctor has the understanding that the patient's time is limited, and that if the disease follows its normal course, the patient would most likely be gone in 6 months. What that doesn't mean is that if the patient's still with us in 6 months, they no longer qualify. As long as that patient shows signs of decline, the patient continues to qualify, and the patient's being monitored every month by the physician and the hospice team to make sure that they still meet criteria. And I'm happy to say we have patients who graduate from hospice, and there's no better feeling because of the quality of care that they're receiving. Hospice extends life. I talked about that. Studies have proven that patients who receive hospice care actually live longer than patients who do not, because of the supportive team that is surrounding them. Early engagement of hospice services frequently lead to longer and better quality of life. I could give you thousands and thousands of testimonials from our caregivers who come to me and say, I wish I would have called you sooner. I couldn't have done this without you. Thank you so much. That's what our team is there to do. Not only help with the patient, but the caregiver who's left behind, who has to watch this patient decline. It's not an easy thing to do. So we're there to help them through that journey. Families cope better. The surviving spouses recover sooner when part of hospice for even just a few days, because they're reassured that their affairs are in order, that their loved one is not left alone, that we are still going to be there to provide those bereavement services, memorial services, one-on-one counseling sessions. We aren't just leaving them behind. They're a person, they mean something to us. Next. The most frequent quote, and I probably hear this 10 times a day, every day. I wish I would have called you sooner. I don't even know what to say to that, because we live in a society where we treat, or we fight. And there are times when that's necessary. But there are other times when we have to be realistic. If you're given a terminal illness, the results are going to be death. That's part of life. Death is part of life. And unfortunately, nobody wants to talk about it. Everybody shies away from it, and that's why they put the walls up when it comes to hospice. I don't want to talk about it. I don't want to talk about death. It's the one thing in life that we're guaranteed. So why not talk about it? Allow your wishes to be known, and allow the team to come in and help you with those things. It's not about giving up. It's about being realistic. Next. Palliative care, and I know this is a big one. Palliative care definition is treatment that enhances comfort. It's not curative. So suppose we have a patient who has a diagnosis of throat cancer, and they've developed tumors in their throat, and they're a hospice patient. And the doctor says, those tumors are really causing a lot of pain and anxiety. We should probably maybe do some radiation on the patient to try to shrink those tumors. That patient can remain in hospice and receive that treatment. They do have to understand that it's short term, and typically we're talking with the doctor about that. You know, the doctor might say 2 radiation treatments should probably ease that and help that. We would agree to eat that cost to keep the patient in the program and not take the team away. And I will tell you, don't ever just assume that, well, the patient's getting treatment so they're not hospice appropriate. That's not true. Oftentimes we allow therapies and we allow other aggressive treatments to happen with the knowledge that it's short term. If it helps, we might do this once or twice to see if it helps. We've done that with blood transfusions. We've done it with IV therapy. but it's always the understanding that it's short term. Okay? The expected outcome is relief from distressing symptoms and the easing of the pain. Again, it's not curative. It's part of the hospice care, but is available for anyone wanting relief of symptoms. So it is available, and we would look at that case by case. We wouldn't just rule it out. We would look at it, and if we can do it, we do it. Curative versus palliative care. Curative care focuses on the quantity of life and prolonging of life. Palliative care focuses on quality of life and relief of symptoms, and they can be in conjunction with each other. When I explain hospice, what I say to families is, you've been given this diagnosis, which we know there's no cure for, so we're going to come in and manage those symptoms. We concentrate on the symptoms, not the disease. We don't give the disease any power. We don't even talk about the disease other than what's happening with the body. But we don't concentrate on the cancer. We don't concentrate on CHF. We concentrate on the symptoms that that disease is causing, and we try our very best to alleviate those symptoms. Next. Hospice definition. Hospice is not a place, but a philosophy of care. Again, we concentrate on the symptoms of the disease, not the disease. Our focus is on living final days to the fullest in the manner chosen by the patient and family. And I can use my patient as an example of this. She made all of her decisions right up front. She knew what she wanted, she voiced her concerns, and probably her biggest worry was her son, who was her caretaker. She was worried, how's he going to be without me? Will he be okay? And we were able to get all of her affairs in order, and she was able to pass peacefully. She was comfortable, and all of her affairs were in order. The family that talks together stays together. I see that in hospice all the time. Families that communicate and they're able to talk about the difficult subjects tend to be able to spend the rest of their time loving their loved one, as opposed to pointing fingers at each other and casting blame. Provide support and care for those in the last phases of life-limiting illness. We are always there to educate the family and to help them through their journey. Recognizes death as the final stage of life, not the enemy. It's going to happen to all of us, and we have to be realistic about it. Affirms life and neither hastens nor postpones death. This is always a big topic too when I'm talking to families. Well, are you going to medicate them and cause them to die quicker? And then you have to explain to them the disease progression and what's happening to the body, that it's really not the medication, it's the body breaking down naturally. That's what happens. And we're continually educating the patients on this as we go through the journey. Palliative care is part of hospice to alleviate pain and other symptoms. And again, we talked about that with the tumors. Next. It's about how we live, not how we die. Learn about your options, choices, and decisions. Know what's available. This is a great resource because many people don't even know hospice exists or what hospice does. I usually hear, well, it's too early for hospice. We don't want to call them in. Really, well, tell me what's going on with the patient. And then they start to give me a synopsis of what's happening with the patient. And in the back of my mind, I'm thinking, this patient's appropriate. So then I go into, this is available for the patient, and this is why. And I explain to them why hospice is an option for them. Implement your advanced directive plans. We see this a lot with young patients who are newly diagnosed with an illness, and they have nothing in place. And I'm guilty of that too. I talk about it all the time, but I'm just as guilty. Because we don't think we're going to die till we're old. We don't know that. So it's so important to have an advance directive and a living will. And for those patients who don't, the social worker helps to implement those things. So they don't have to try to scramble and do all of that while they're dealing with a terminal illness. Voice your decisions about hospice. When I go out and talk with the family about hospice, I never really know where they're at in their thinking process. I receive a referral from the doctor, but I don't really know how the patient is reacting to that. So when I go in to talk to somebody, I listen a lot more than I talk. Try to figure out where they are in the process. Are they still in fight mode? And if they are, that's fine and that's their choice. But I offer them different options that are available. And then you have families that are pretty clear cut. When I come in, they'll say, I don't want to go back to the hospital. I don't want to be stuck again. I don't want to be put through tests. Okay, you're ready for hospice. And that's what most people want. They want to stay home. They don't want to be transported to and from the hospital. They don't want to die in an environment where they know nobody. They want to be at home, surrounded by loved ones. And hospice allows that to happen. Engage others to learn more about hospice. I hope that I'm able to give you knowledge today that you can pass on to other people. Next. Core aspects of hospice. We are patient-family focused. We have an interdisciplinary team that focuses on the patient and the family that we continually focus on until they're no longer with us. We provide a range of services. The interdisciplinary case management, that's the RN case manager, who typically goes into the home or the patient's environment 1 to 2 times per week, focusing on comfort care, symptom management, bowel regimen. You don't know how many times that the bowel regimen is more important to the patient than the pain. I see that every day. So we help to make sure that those things are managed. Sleeping is another big one. If the patient's not sleeping, the patient is uncomfortable, they're cranky, they're irritable. So we make sure that that's happening for the patient as well. Pharmaceuticals. We have our own pharmacy that we order our medications through. When a patient's admitted to the program, if their diagnosis is congestive heart failure, all of the medications that pertain to the diagnosis is covered by hospice, which alleviates some financial burden for the families. Durable medical equipment. All of the equipment necessary to make the patient comfortable, we become responsible for. Hospital bed, bedside commode, whatever they need to help them, we are able to order and get in place. Supplies, baby wipes, adult briefs, any supplies that they need for their illness, hospice covers. Again, that alleviates a lot of the financial burden to the family. Volunteers. There's nothing better than one-on-one with somebody who didn't know you initially but became part of your family at the end of your life. There's no greater reward. Grief support. I'm happy to say that we not only provide grief support to our families but also families in the community. If they need a support group, even if they weren't part of our hospice family or part of the hospice program, that support group is open to them. Hospice team members, the patient's personal physician. So many people think that when a patient elects hospice that their physician is no longer involved. That is untrue. Most of our patients are still being seen by their primary care physician who knows the patient, which is very important. The hospice physician, we have a full-time hospice medical director who oversees each case and make sure that the patient continues to qualify and that we abide by Medicare guidelines, which we're bound to do. The nurses, which I had said previously, cover symptom management and comfort control. Home health aides are probably our biggest asset. I can't say enough good things about them. They really get in there, they know the family, they do all the bathing, changing linens, they paint fingernails and toenails, and they make these patients feel so special. And they are the ones that develop such deep, deep feelings for each other. When we go back and we talk to families after the death has occurred, who was the biggest asset? It's always the home health aide. Because they're the ones down there, getting into the nitty-gritty and helping that patient. It's meaningful. Social workers. Social workers are wonderful too. They typically help with anything that is non-clinical. Your advance directives, your living wills, your Medicaid applications. Most things that are non-medical, the social worker is handling. Family dynamics, that happens quite a bit where people are going like this. They do a lot of counseling, bringing people together, trying to make them realize what's best for the patient. Our clergy or our counselors. Our clergy are non-denominational. They meet the patient wherever they are in their journey. You know, patients are very, they let their needs be known. So if you go in and they say, I don't need a clergy, I have my own, that's your choice, absolutely. Or, I don't believe, that's your choice too. Then the clergy's not an option. But we let people know that it's there. If it's meaningful to you and you feel it's beneficial, it's available. Trained volunteers. Volunteers can't do anything clinical. So volunteers cannot administer meds or feed a patient or help with any of those needs. But they can sit with the patient, run errands, give a caregiver a break so she can go take a nap because maybe they've been up all night with the patient. And they develop meaningful relationships with the patients. Speech, physical, and occupational therapies. So many people think that when a patient's in hospice, they can't have these therapies. That's not true. If we have a patient who's having trouble transferring or getting from bed to chair or bed to bathroom, we have these therapies available to help with those things. And we can offer that short term if the doctor feels it's necessary. So it is available. Next. The hospice team duties. We developed a plan of care which is individualized for each patient. We don't treat everybody the same. We determine their needs and we help them with those needs. We manage their pain and their symptoms so that they can live what life they have left with quality of life. We attend to the emotional, psychological, spiritual aspects of dying and caregiving, and that doesn't end when the patient dies. We are still there months after the patient is gone. We are continually teaching the family what's going on with the patient. So often, if you've never taken care of a dying patient, you don't know what to expect. You have no idea what's next. And the nurse is continually educating the family to make them aware. This is normal. This is what you might see next. If you're in a crisis situation, you can always call us. We're available 24/7. That sense of security is huge to families who are out there trying to do it on their own. We advocate for the patient and family. We are the middleman between the family and the doctor, or the facility and the doctor. So we take the time to make necessary medication changes or any other type of change. Take that away from the family. Provide bereavement care and counseling 13 months after the patient dies, and longer if needed. Where hospice is provided anywhere the patient's at. That can be home, a nursing home, assisted living facility, hospital, hospice residence or units, group homes, prisons, and we have gone to prisons, homeless. Wherever the patient's at, that's where we go. Hospice levels of care. Most of our care is provided as routine home care, and those are your home patients, your assisted livings, your nursing home patients. That's all routine home care. We also have respite care, which is provided for the caregiver's relief. So if the caregiver is exhausted or they want to go on vacation, the patient goes into a skilled nursing facility, typically for 5 days. That's covered under their Medicare benefit. There's no charge to the family for that care. So I always encourage families, when you get to that point where you're stressed, take care of yourself. Let's put the patient in respite care, give you a little time to recharge your batteries. Everybody needs that, even people like us who aren't taking care of a terminally ill patient. Take advantage of it. It's all inclusive in that benefit. General inpatient, that's usually provided in a hospital. And we use that level of care when we are not able to manage that patient at home. When we've tried everything to relieve symptoms and to get them controlled and we just aren't able to do it, then we send them in for general inpatient. It's a short-term level of care, and when those symptoms are managed, the patient goes back to their environment. But it is available. Continuous care is very similar to general inpatient, but it's in the patient's home or wherever they are. Typically what happens is if their symptoms are unmanaged, we send a nurse to the bedside. The nurse stays there to administer medications, symptom management, calling the doctor, educating the family, and her goal is to manage those symptoms. If she's not able to do that, then we might need to look at general inpatient. Typically we're able to do that at the bedside, so we don't have to transport the patient out and keep them in their environment. Additional services. Hospice of the Piedmont offers additional services, including we have a hospice house, which is an 8-bed colonial home that was built in the 1800s. You walk in there and you feel like you're at home. Volunteers are there to greet you. The patient is treated with dignity, 24-hour care. The patient does have to be terminal to typically qualify to go to the hospice house. We typically look at 2 weeks or less to live. Or it can be utilized for respite care, which is wonderful because most people don't want to leave. I will tell you with the hospice house, it's generally $170 per day, unless they're receiving respite care, and of course we eat that cost. So room and board is not covered at the hospice house. But for families who get to that point where they're just not able to manage the patient at home, and we know that the patient's time is limited, it's a resource for them, and it takes a huge relief off of them. Inpatient care, we are opening an inpatient unit over at the old UVA in the ALCA building, which will be 10 beds. It will be available for those patients who qualify for inpatient. It's going to be huge for the UVA patients who are being shipped out to the home but unable to be managed. We can send them over to the inpatient unit where they get 24/7 care. Complementary therapies. Again, that would include your physical therapies, your occupational therapies, and your speech therapies, if those therapies are beneficial to the patient. We also have a specialized pediatric team, which we team up with Continuum. We don't usually get a lot of pediatric patients, thank goodness. But if we do team up with them, and we guide that case. So who pays for hospice care? This is a big one because usually when I go out to talk to families, that's the first thing they say. Who's paying for this? Right? I would have the same question, for sure. Hospice care is covered at 100% under the Medicare A benefit. Why would you not tap into that? There's no charge. Plus we are covering supplies and medications and durable medical equipment. It's all inclusive. It's also covered under Medicaid, and all private insurances are required to have a hospice benefit. I think that is happening today. There was a time when not all of them were, but that is a guideline that was set many years ago. So it does have to be offered with all private insurances. And of course, sometimes it's in combination with the 3 different ones, depending on what insurance the patient has. But the bottom line is, hospice is covered, Medicare, Medicaid, and all private insurances. And if we receive a referral on a patient that has no insurance, and this happens occasionally, but that patient's hospice appropriate, we are not going to turn that patient down. We will eat the cost and take care of the patient, because that's what's best. So remember that if you have somebody who's uninsured. Admission criteria. The patient has to have a life-limiting illness with a prognosis of 6 months or less if the disease follows its natural course. And again, if the patient's still alive in 6 months, that does not mean that they no longer qualify. They have to live within our service area. We do cover a 50-mile radius, and we also have a team in Rapidan, which goes all the way out to Warrenton and Culpeper, Orange, Madison. So we cover all of those areas. The consent to accept services. Of course, when you speak with the patient, they have to be accepting of our service, and they have to understand the guidelines that go along with it. And that's our job, to educate them and make them aware. Specific to hospice diagnosis, Medicare has set the criteria for hospice. It's up to us to abide by that. And I can tell you at Hospice of the Piedmont we do that. We try very hard to get patients in, but under Medicare guidelines. Suggest hospice care when one or more of the following occur. This is what I tell my facilities when they're questioning as to whether or not a patient's going to qualify. They'll say, well, I don't think the patient has 6 months or less to live. I don't think they're going to qualify. So then I start to triage and I'll say, has the patient had any frequent falls? Do you see general decline in the patient? What about weight loss? That one's huge. Multiple comorbidities. Multiple ER stays. If that patient's being sent out 3 or 4 times a month, they're most likely hospice appropriate. They're expressed to desire to stay at home. If the patient gets to that point where they have a terminal illness and they say, I don't want to go back and forth to and from the hospital where I'm susceptible to germs and other illnesses, and I'm not with the people I love, typically hospice is appropriate. Their serum albumin is less than 2.5, dependent on most daily activities, which is their ADLs, feeding, going to the restroom. That's another question that I usually ask. Is the patient bedbound? Is the patient incontinent? Their desire for comfort care and non-aggressive treatment. And usually when we get the referral, the doctor's had that conversation. They might not go very deep with that patient because, they're usually programmed to treat. But many doctors, when they get to that point, they have that frank conversation with the family, and then they call on us. How do I talk about hospice? You set the stage. You figure out what their needs are before you just start spouting out what hospice does. Find out what their wants and desires are. Get the information, give the information, provide support, and come up with a plan. I'm never there to convince. I'm not an aggressive person. I believe in hospice. It's my passion, and I know it works because I've seen it work over the years. But I never go in there with the intent that I'm going to get this patient today. I want to find out what's going on with this patient and how I can help. And if it's not hospice, I'm going to give them other resources like home health or private duty or other resources in the community that can help them. And it also gives me an opportunity to educate them on what to look for to make that patient hospice appropriate. What changes with hospice? All coverage of the hospice-related diagnosis is covered under the Medicare benefit. That includes no aggressive therapies, the medications, the equipment, and the supplies. This next one is huge. When a patient elects hospice, hospice becomes 911. What that means is there's somebody on the other end of the phone, just like if you would call 911. That nurse is going to triage the call. If she can instruct the family as to what to do over the phone, then that's what she does. If the patient's in a crisis situation and the nurse realizes that, we send a nurse to that family so that they don't have to go to and from the hospital. We also make them aware that if they do call 911, they may receive a bill because it's a hospice patient. Now, if it's unrelated to the hospice diagnosis, suppose we have a patient with a diagnosis of congestive heart failure and they fall and break a hip and they end up at Martha Jefferson Hospital. They can still continue treatment because it's unrelated to their hospice diagnosis, and we still continue to provide care for the hospice diagnosis. So that's a big one, and you really have to reinforce that with families because we are programmed to call 911. But once the team is in place and they're comfortable with all of us, they're perfectly fine with calling us to say, hey, this is what's going on. And plus, we know the patient. The non-hospice related diagnoses are still covered by regular Medicare, as I said before. So that does not impact hospice at all. Now, if it's related to the hospice diagnosis, hospice has to discharge that patient so that that patient does not receive a bill. But please know that a patient can enter hospice and discharge hospice as many times as they would like. We don't encourage that, but it happens, and it's okay. Coordinating with hospice. Continue to provide quality of care. Hospice care is not 24/7. but we're available 24/7. So in the middle of the night, if you're having a situation that you can't control, you call us. We triage the call or we send somebody to you. In addition, support is needed beyond the family. We help with hiring caregivers to come in, private duty. Now that is an expense to the family, but we're able to help coordinate that, to help the family. The hospice social worker is available to assist with this process. Allow the patient and family to recognize the benefits of our joint relationship. And we do work hand in hand with private duty agencies, and we're happy to have them. Communicate, communicate, communicate. I can't stress that enough. Don't assume it happened. Communicate it, document it. It's nursing 101. If it's not documented, it didn't happen. Hospice provides hope, which so many people are not aware of. We ensure the best personalized quality of life for the rest of your life. Control pain, manage physical symptoms, assess and tend to changing needs, aid with personal care, guide through advanced care, planning with forms and financial care needs. We take all of that off of the patient's plate so that they can spend their time loving those that they love. Provide medication, hospital beds at home, durable medical equipment, and supplies, and it's all covered under their Medicare benefit. Support and teach the family, caregivers through the changes. Again, it's hard to be a caregiver. It's hard to watch somebody you love decline and become somebody that you don't recognize. Our team helps to educate that caregiver and help them through that process. Offer supportive spiritual care to cope with core life, meaningful questions, loss, grief, fear, guilt, and more. Most caregivers feel guilt. They feel like, I didn't do enough. Or, why didn't I do this? I wish I could have changed that. We try really hard to make caregivers aware that they're doing their best. Don't carry that guilt with you. You've done everything you can for this patient. And I hope that we achieve that because it's bred into us. That's who we are. And as women, I think we're the worst because we tend to take care of people. Walk with, guide through, help navigate this difficult journey. Provide bereavement counseling for up to 13 months after the death. 8 elements of quality of life for the last phase of life. The opportunity to discuss and plan for end of life. Trustworthy assurance that physical and mental suffering will be carefully attended to and comfort measures intently secured. Trustworthy assurance that preferences for withholding or withdrawing life-sustaining intervention will be honored. That is so important because we want the patient to be the one to make the decisions, and it's our job to help them and also make sure that those wishes are being honored. I want that for myself, and I want that for every patient. It's their right. Trustworthy assurance that there will be no abandonment by physicians. Like I said, most of our patients are still being seen by their primary care physician that's been involved in their care for years. That's a great reassurance for patients. Trustworthy assurance that dignity will be a priority. Dignity. What the patient wants and desires is honored. Trustworthy assurance that burden to the family and others will be minimized. So often, if there's unfinished business with a patient, and I've seen this throughout my career, they have a very difficult time passing because they have unfinished business that they never attended to. The social worker is able to really get in there and tend to those needs and help that patient to pass on and be okay with it. And also the family members that are left behind that they have the unfinished business with, they're able to move on. And that's so important for all of us. Attention to personal goals of the dying person. And I've seen quite a few over the years. I remember a patient when I first began my hospice career that she was diagnosed with ovarian cancer. She was in her 20s. She had 3 kids. This was all brand new. She wasn't going to see them graduate. She wasn't going to be able to attend weddings. She was not going to be there for their significant things in life. So her request was to write letters to each one of these children for the day they got married, when they graduated, and she did that. How important is that? I would love to have a letter from my grandparents to look back on, to see the love. And the social worker was able to do that, and she created a scrapbook for each one of those children. And their mother is the one who navigated it. It's pretty amazing stuff. Trustworthy assurance that care providers will assist the bereaved through the early stage of mourning and adjustment. We don't leave the patient behind. Needs for the patient's well-being. We attend to the physical needs with our physicians, nurses, and aides. The emotional needs with our social workers, chaplains, and counselors. Spiritual needs with our chaplains. Family and caregiver, the whole team, volunteers, therapists, and counselors. Social, friends, community, and volunteers. And Hospice of the Piedmont is big with giving back to the community. We strive to do that and to make it known what hospice does and what's available. That's it. That's it. Does anybody have any questions?